So we've heard a little bit about aortic disease tonight. We've heard a little bit about peripheral arterial disease, and obviously, you know, we could spend a whole weekend talking about these topics and not really cover everything. But to kind of round it out just a little bit, we're going to spend some time attending to the problems that affect the veins, and we're probably all familiar with varicose veins. Does anybody have varicose veins in the audience? Varicose veins? No, that's not too bad. Anybody ever have a DVT? A blood clot in their leg? I know I don't want to be a HIPAA violator here, but so a few people. So one of the things we've learned over the last decade is that, you know, we've known about varicose veins for a long time. We know about DVTs, but what we didn't appreciate is that patients can get blockages in the deep veins in their legs. The deep veins being the main pipe. If you can imagine 95 versus the Merritt Parkway, right? And the Merritt Parkway has one lane down. It's a small road compared to 95 with its 3 lanes. So you want to keep the 3 lanes open. You want to keep the blood flowing out of your leg. And if you don't, you run into all kinds of problems. So what I want to focus on now is talking about outflow obstruction. And the most critical veins that we think of in this area are the one in your groin, the common femoral vein, and the iliac veins, which are up in the pelvis. As you know, those veins come back up to around the level of the belly button, and they form the inferior vena cava, which drains the blood back to your heart. So if you have blockages in these main veins, you have a lot of problems in your legs. Bart, if you would advance for me, please. So it's not an uncommon problem. If you look at the American population, about 40% of the American population has some form of venous disease. 24 million people have varicose veins of some sort. But 6 million people will have skin changes, will have discoloration, thickening of the skin, and about 500,000 patients a year have ulcers, actual breakdown of the skin, because they develop so much blockage in the blood getting out of their leg due to venous disease that the skin starts to break down, and these can be some of the most difficult wounds to heal. Anybody here at a wound center? Okay, so you know exactly what we're talking about here in venous ulcers. Next one, please. And these are the types of things you can see. On the left, you got a patient with a swollen leg. The skin has started to get dark and brown. Or you can see in the middle slide, I hope it projects to the back, the skin has turned red. There's so much inflammation because of the swelling in these legs that not only is this leg swollen, but the skin is starting to get inflamed on its way to deteriorating. And then finally, the patient on the far right has an actual sore. These can take days, but more commonly weeks, months, and sometimes years to heal, and sometimes they just don't heal. And even more importantly, if they do heal, they usually recur, these types of ulcers. And this is how bad it can get. This is a lady who both of her legs were just dying. And I know that was great for dinner talk, but you know, this started as a small wound on each leg, and they just got worse and worse and worse over the course of a year and a half. Next. So these are the types of problems we're talking about. These patients truly have a poor quality of life. They're in the negative range because some of them wish they were dead, because they're going to the doctors every week. They're going to the wound center every week trying to get better, and they're just not. We start the evaluation of these patients with an ultrasound. A lot of times we'll find superficial vein disease, and the traditional treatment would be compression, some kind of Uniboot or a bandage, elastic bandage or compression stockings. About a decade ago, we thought if we add vein ablation, which became a popular and available technology, we would actually affect the healing of these legs. And what we found is that, in fact, if you add vein ablation to the next to standard compression therapy, that you get this. The patient didn't get better, and I heard this over and over again from the wound centers. Yeah, we didn't really see a whole lot of improvement after the vein was ablated. And in fact, there's now multiple studies out, and this is a meta-analysis of 5 randomized controlled studies that show that if you treat the superficial vein, the varicose vein, in somebody who has an ulcer, you will decrease their incidence of recurrence, but you don't actually help them heal any faster. Their healing is fast with the vein ablation and compression as they would if they just got compression. So we have to look beyond a vein ablation as a possible way to get these patients better. And in fact, you can see here in this chart, the patients on the left were patients who only had superficial disease. The patients on the right were patients who had deep and superficial vein disease. And if you compress them, you see an improvement that's steady. But if you do a vein ablation, the patients don't get a whole lot better in addition to compression. So compression plus surgery at the top, compression at the bottom, and there wasn't a huge statistical difference here between the rates of improvement. So if it's not about the superficial disease, then what's it all about? And you really have to think of how else can you treat chronic disease? Well, what's left? If it's not the superficial disease, then think about the deep disease. So the patients we're talking about, as I said, are patients who have blockages in the iliac veins up in the pelvis, the big pipes carrying the blood out of the legs, as well as the common femoral vein in the groin. Some of these patients have had previous pelvic surgery. They may have had a DVT at some point. They may have had radiation therapy to their abdomen or their pelvis because of a prostate cancer or a uterine cancer or something like that. But you want to tease out the patients who have CHF and chronic renal insufficiency because they're going to get swelling and it has nothing to do with the veins. So you want to make sure that you're picking the right patients. And then go back one, Bart. And then these patients are going to have the swelling and the skin changes that we showed in the pictures. Next, please. And there's two types of lesions you're going to find. There's the patient who had the previous DVT, and as that blood clot dissolved, you now have scar in the vein. That's a post-thrombotic change, and that can cause narrowing or disease within the vein. If you imagine shutting 95 down from 3 lanes to 1, what happens? Everything backs up, and you get the same thing in the leg. The blood backs up, and you get swelling, pain, and heaviness in the leg. But the other thing that was figured out about 8 or 10 years ago by a group in the Midwest is that there's a lot of patients who have compression of the veins up in the pelvis, where the artery is pinching the vein. You have 2 arteries that split that can pinch the vein, or the artery can compress the vein up against the spine, the bone, and narrow the vein, and that can cause the breakdown from 3 lanes to 1 and cause problems. And these are the type of lesions that you'll see on the left. Is a standard varicose vein. The vein's enlarged, the valves aren't working very well, and gravity's pulling the blood backwards from the heart down to the foot. But at the bottom, that white scar is not supposed to be there. That's the inside of a vein that had a previous DVT. And so now that vein is filled with scar, and you've gone from 3 lanes down to 1. And the blood's just not moving through very well. Or on the right panel, you see the arrows. The arrows are pointing to places up in the pelvis where those big veins coming out of the legs can be compressed. And there's at least 4 spots that are potentially there for every patient on both the right leg and on the left leg. So how do you figure this out? Well, you can go with the ultrasound. We started with that, and that's a good place to start. You could do a CAT scan or an MRI, but they're not particularly sensitive for picking up a lot of these things. So you can find abnormalities, but if you don't see an abnormality on a CAT scan or MRI, it doesn't mean it's not there. You can do a venogram. You can put a catheter in and shoot some dye, and again, that will pick up some of the lesions, but as it only picks up about 2/3 of the problems. So really, intravascular ultrasound is the best technology. And I'll get into what that is. Yep. In just a second. If you take intravascular ultrasound and you look up into the legs of patients who have the kind of skin changes, swelling, heaviness, and achiness that we talked about in the initial slide, you find that intravascular ultrasound will pick up over 90% of the lesions, whereas venography, which has been the gold standard for the last 3 or 4 decades, misses at least 1/3 of the lesions that are there. And these are the lesions we're looking for. As I showed you in the previous slide, you can have compression at the level of the belly button. You can have compression in the middle of the pelvis, and you can even have compression down in the groins where the vein is narrowed. And if you treat these lesions with a stent, and that is the treatment, angioplasty and stent, what you find is that patients who had pain, about 80% of the time it goes away. If they had an ulcer, about 3/4 of them will go away. And in the past, if you had an ulcer, and you got it to go away, you kept those patients in compression therapy for the rest of their lives, and you prayed that that ulcer wouldn't come back. A lot of these patients, you can not only make their ulcer go away, and this isn't everybody, but many of these patients, you can not only make their ulcer go away, but they don't need to wear compression because it's never coming back. Now, one of the things that gave me some concern when we first started looking at this around 2007 is you're putting a foreign body into the vein. Now, what happens when blood gets screwed up in the veins? You get a DVT, right? So I thought, geez, I'm putting this foreign body in the veins. I'm going to cause a bunch of DVTs. Well, this study out of 2007, looking at almost 1,000 interventions in patients who had some of them had prior DVTs, so a group at risk for another DVT, showed that the incidence of a DVT after this intervention, which is stenting of these vein lesions, was only 1.5% in the first 30 days, and it was only about 3% going out as far as 10 years. So the risk of having a DVT is very low, and I will tell you that over the last 8 years now since this paper came out, our understanding of how to interact anticoagulation, with stents, when to treat, when not to treat, has evolved significantly. So the incidence wasn't that high, and I would challenge to say that we've gotten that much better. So how do we look at these lesions? Well, I mentioned that IVUS was probably the best treatment, but if you do a venogram, so you've put a needle in the vein, you shoot some dye, and you see a blockage like this, you know you got a problem. So diagnosing the problem is not so much of a challenge when it's there. But as I said, the venogram is going to miss the lesion at least a third of the time. Does anybody see a narrowing here that they'd want to put a stent in? Anybody want to raise your hand? Dr. Lancaster? Dr. Moose? Say no. No, I'm kidding. So I don't see one either. And Karen, do you see anything? You've seen a lot of these. Karen's one of our nurses down in Norwalk, and she's seen me do more of these than she probably cares to say. Next one, please. So there really isn't anything you would go after. If you use the intravascular ultrasound system, this is a percutaneous procedure. So much like you put a wire and catheter in, a balloon and a stent to treat the blockages in the heart or in the legs, you do the same thing in the veins. And you put this small catheter in over a wire, and you can see quite a bit. These are the types of lesions that you're going to see. If you look, I'm going to kill my video guy here. If you look here, this is a wide open vein. If you look here, the vein is narrowed right around the catheter. You see the vein is flattened, and the vein is almost non-existent on the slides. And so those are the types of things you can pick up with intravascular ultrasound. Now, if you look at the venogram on the left, you say, well, yeah, I can see that on the venogram, duh. And that's true. But let me show you some where you may not be so obvious. So this was a 65-year-old lady. She had left leg problems for many years. She had swelling and heaviness, pain in her leg. So by the end of the day, her leg felt like an anchor. So she'd go home, lay on the couch, put her leg up to spend about a half an hour to 45 minutes before she felt better. When you looked at her leg, she had some swelling. She had a little bit of redness in the calf, what we call stasis dermatitis, that inflammation. Next part. She hadn't had any prior vein disease. This is what it looked like. You see the swelling there. She actually had this bilaterally, but we'll focus on the left for the purpose of illustration. She had no prior vein disease. She had minimal superficial disease, so didn't really have varicose veins. And she wasn't a kidney failure patient or a heart failure patient who had swelling from another reason. This is the venogram. So there's the dye going up through the vein. That's the hip bone, so that's right in the groin, going up into the pelvis. And you can see it's going through nicely. There's really no real narrowing there. Next, please. And that's what it looked like. That was the picture I showed you a few minutes ago. When you slow it down and easier with the lights off. This is the intravascular ultrasound. In the middle, that big white circle is the a catheter. That's the inferior vena cava. It's a wire going into the other leg. You see the artery coming in over the top here. It's compressing the vein, but it's not really narrowing it. This is right below the aorta. This is the iliac artery. Up at around 2 o'clock is the iliac artery next to the vein. The vein has the catheter, that big white circle in the middle of it. The artery is going to split here into two branches. It's going to go into the internal and external iliac artery right there. Keep an eye on the vein in the middle at around 6 o'clock, where the catheter is at the top of it. Because right now it's a little narrowed, flattened rather, not particularly narrowed. But here it starts to get compressed. And if you give me a second longer here, you're going to see that the vein goes to just about nothing. Now you saw the venogram. That looked pretty normal, right? The wide open pipe, the blood moving right through. That's what this patient had. She actually had it on both sides. So this is compression of the external iliac vein, and that's the vein just below that. So it's about a centimeter long lesion, maybe half an inch, and then it goes back to a perfectly normal vein. Next one, please. So that's what you saw, right? On the right is the normal vein. On the left is the narrowed vein. That's a good 75-80% narrowing. Next one. And this is after we put a stent in there. Just a puncture in the skin, balloon and stent. Next, please. This is what the intravascular ultrasound looked like after. Again, starting in the inferior vena cava, we see the artery coming over and compressing the vein, but not really narrowing it. And then we're going to come down a little bit. There's the artery at about 2 o'clock, the vein at around right in the middle there. And right about now, we're going to see the stent show up. That's the stent inside the vein. And you see the artery split there. That's where we started to see the narrowing. And now there's no more narrowing. We've opened up the vein. Next part, please. So this patient came back to see me the next week, and her first comment was, I can see my ankles again. She hadn't seen them in 3 years. The redness went away, the heaviness and achiness went away. I've been following her well over 2 years now, and she continues to have no recurrent problems and is doing quite well and quite pleased, and has had no complications. Just to change gears for just a second to talk a little bit about the patients who have had prior DVT and now have scar in their vein. Next, please. You can have all kinds of findings with intravascular ultrasound on the wall of the vein to identify this. You can see these bright spots we call hyperechoic changes. The vein can be small and narrowed and all irregular in shape. Or you can actually see what looks like a little net or a web inside the vein, and we'll show you a couple of those. Next part. So you can see up on the left, the vein pointed out as common iliac vein in red, CIV, is small and narrowed. On the right is what a normal vein would look like. So this is a vein that's been scarred down from a prior DVT, and when that DVT went away, this was the scarred down, narrowed vein that you have left. On the bottom, you can see, again, the vein is a bit irregular in shape. On the right, it's big and plump and round and smooth. So you can see the difference between normal and abnormal. Next, please. On the top, on the left, you can see that white line going right up through that vein. That's a web. So that's like a piece of scar tissue dividing the vein in half, or maybe into quarters, or maybe into thirds, and causes outflow narrowing. Again, taking one lane out of 3 is going to cause problems. On the right is normal. This is a patient who had a web. So this is a very subtle finding. You'd never see this on a CAT scan, an MRI. You won't even see this on a venogram, but you can pick this up with intravascular ultrasound. And it's going to look like not much of anything, but hopefully I'll convince you it is. Next. So this is a venogram, pretty normal looking. The vein's quite plump and full, and the flow moved through the vein quite normally. I'm pointing this out because when we actually, if we can put the lights down just a tad, when we show the video, it may be hard to see, but there's a little white line there, and that's a web. Now, you're not going to believe me because I wasn't sure I believed myself when I first saw this, but I'm going to try to convince you. Turn that on next. So you can see it's just going to loop around a few times. You can see that little white line just off to the left side of the IVUS catheter, that big white circle. Can you see it in the back? I know it's a little bright in here. Okay, so you look at it and you go, geez, you're only moving that catheter about a millimeter, a half a millimeter. Is that real? So I said, I don't know if it's real either. So I said, Karen, can you get me a balloon? I need to put a balloon up. So let's put a balloon up, Bart. And there you go. You see this tight web. And actually, I will tell you that I took my foot off the pedal as we inflated this balloon because there was such a tight narrowing. I was even surprised how tight it was. And it was a little slow getting my foot off the pedal because this narrowing, you can see that indentation there was actually much tighter earlier in that inflation. Next, please. And so we stented that up just as we had the previous patient. And this patient had the swelling, the heaviness, and the achiness in the leg. And you look at that little thing, you go, really? Was that it? And the patient's symptoms go away. We've now seen a half a dozen of these very subtle findings that you only pick up with intravascular ultrasound. So as Bart mentioned in the beginning of the talks, imaging has made a major improvement and been a major factor in all the minimally invasive technologies we can use. Because if you can't see it while you're fixing it, you can't fix it. And just a couple more comments. I started doing this in around 2007 because we were seeing the kind of wound patients you're seeing in the clinic where the venous ulcers weren't getting better. And I'd wrap them in an Uniboot, and I'd been doing this since I was a resident, so that's just about 4 or 5 years. But they weren't getting better. And so what I ended up doing, I said, well, we got to do something different. And so I started thinking about the deep veins. And so I looked at our first 4 or 5 years of experience treating the patients we talked about earlier. Next part. And again, patients 58 years average, but some of them were 29, some were 84. And we put a number of stents in them. Go ahead. We followed them out. I had, at that time, 15-month follow-up on average clinically. Some of them were out to 3 years. We had ultrasound that was a little less than that, but again, over 2 years. I can tell you that I've been following these patients now out since 2007, so we're starting to get up to 8 years follow-up. Next. These were the patients. This is their classification: ulcers, swelling, pain, skin changes. Next. And you see about 89% of the patients were improved. Not everybody was cured, and not everybody who was improved was symptom-free, but everybody felt better, and their legs are doing better afterwards. Next. And if you look at this graph, SEEP3 is swelling, SEEP 6 on the right is an ulcer, and then in between are the patient's different grades along that range of debilitated leg. The blue is what the patients reported as their symptoms prior to the procedure. The red is their symptoms after the procedure. And you can see no matter what they started with, the patients felt better when you find a lesion. Now, not everybody has a lesion. About 20% of the time, we'll go ahead and take a look and don't find an explanation for their venous disease. But in the patients, we find a tight narrowing or tight compression or a web. When we stent those patients, they get better. So we've kind of moved away from this. These old-fashioned bandages. This is part of the treatment. It's not that we don't do this, but we don't count on this being our only treatment. We now look for an underlying cause of the venous disease, and we supplement it with compression to try to get these wounds to heal. Go ahead. And this is a lady who, as I told you, her wounds were getting worse for a year and a half. And we're now getting to this point where a couple months later she was totally healed. It took us about 8 months to heal those massive wounds in her thighs. But she's now about 4 years out and has had no recurrences. So this works. It's not a single discipline venture. It's not just what a vascular surgeon is going to do, but it's a vascular surgeon with infectious disease, wound care, and everybody who's involved in wound care. But you can get happy results, and this was our team at Norwalk. Next. So many patients suffer from advanced, untreated chronic venous hypertension. A lot of this is due to outflow obstruction and intravascular ultrasound, I feel, is the gold standard. And I think most of us who do a lot of this would agree. And so we need to look for these patients. So if you have a patient who's got venous symptoms, especially if they've already had their vein ablated and they're just not getting better, this is the next step. And you have a card at your table. I'm going to take the privilege of the podium. You have a card at your table. We're doing clinical trials on this. Not everybody needs a clinical trial, but we are doing a clinical trial on this to test this new venous stent that Cook is doing. But we're doing it at these, and this is something that can easily be done at any community hospital. This is something that's an outpatient procedure. You can do it in the cath lab. You got intravascular ultrasound. You can find these lesions. You can treat them, and it's oftentimes an outpatient procedure. And so it can be done under local anesthesia with sedation, and it's very gratifying. And I have to say, I'm passionate, and I apologize.